that we will be recording the conversation. So in terms of agenda, we will begin with a few questions for our panelists, and then we're going to open it up for a few questions and a larger discussion at the end. If you have any discussions or any questions for the discussion, please post them in the chat box unless the panelists directly ask for audience participation, which is definitely encouraged if they do. Please join in that. And if we do run out of time before we get to your question, we will follow up with a response via email within the next few days. And this is another reason why it's important to please just provide your name and email in the chat box if you haven't already. We want to make sure that we can get that to you. All right, wonderful. Well, now we're going to just briefly introduce each of our expert panelists. To begin, we have Amy Hequembourg, Associate Professor here at the School of Nursing. Amy received her PhD in sociology at UB and completed a 3-year postdoctoral fellowship in alcohol etiology at UB's Research Institute on Addictions. Her research focuses on health disparities among sexual minorities with an emphasis on interpersonal violence, sources of minority stress, and health risk behaviors among these populations. Amy, want to give us a wave just so we all know where you are? Wonderful, thank you. Next, we're joined by Kyle Brown, a 2020 grad from our Doctor of Nursing Practice Family Nurse Practitioner program. Kyle is an intensive care nurse in Buffalo, where he has been caring for patients afflicted with COVID-19. His doctoral studies have focused primarily on LGBTQ+ health disparities, with an emphasis on healthcare providers' LGBT health perceptions, the contribution of uninformed care toward LGBTQ+ health, and the impact of HIV among LGBTQ+ adults. Kyle, want to just let everyone know where you are? Thank you, Kyle. And then last but not least, we have Caitlin Nye, a 2nd-year PhD student here at the School of Nursing. She is currently the Nurse Residency Program Coordinator at SUNY Upstate University Hospital in Syracuse. Her doctoral research will focus on improving the preparation and self-efficacy of nursing faculty to include LGBTQ+ health topics in undergraduate nursing curricula. So just to begin, before we jump into full-blown questions, can you just each tell us a little bit about what experiences led you to study this field? Amy, if you want to start.
Oh, I was actually going to weave that into my introduction, but I actually became interested in SGM populations, very specifically focused on experiences of lesbian moms in grad school. That was back in the 1990s, and I conducted research to explore their parenting experiences from a qualitative perspective. And my work has morphed over time as I joined the Research Institute on Addictions. I ended up being interested more broadly in health disparities and risky health behaviors among SGM folks. And so that's where I am today.
Wonderful, thank you, Amy. Kyle, how about you?
So there's actually several different reasons that I decided to focus my research interest on LGBT health, but I would say that the primary reasons are, well, for starters, identifying as part of the LGBT community and understanding a lot of the struggles that members of the LGBT community happen to go through, identifying as a gay male myself. But then I think that secondly, I have always found myself interested in populations that I feel are marginalized, and especially marginalized politically. I think that I find myself to be drawn towards like political aspects of health. And so with everything that's been happening in the past decades, addressing LGBT health disparities on the political level, for instance, with during the Obama administration with the legalization of same-sex marriage on a federal level, those things kind of drew me into focusing more on LGBT health. And because ultimately I have come to find, being a member of the LGBT community, that healthcare providers are often uninformed on how to properly care for LGBT adults. So that's primarily why.
Wonderful, thank you for sharing that, Kyle. Caitlin, would you like to let us know what got you into the field?
Sure. So like Kyle, I also identify as a member of the LGBTQ community, which, each of those populations and we can talk about this more as we go along, may have different sorts of unique health considerations. They're not a unified block of folks. Someone who's trans and using hormones may have very different health needs than Amy's original research patient population of lesbian moms, for example. But if it's okay for me to share sort of a personal anecdote from my undergraduate training as a nursing student, I remember being in a large lecture on the subject of hepatopathology, liver disease, and transplant. And we had someone who was a specialist from the transplant center at the hospital affiliated with my nursing program, who, as part of her lecture about liver disease, made a very offhand comment about, well, you know, gay men are at higher risk for hepatitis B and C, and was just going to kind of continue on with her lecture. And as a second degree BSN student, I said, well, why? And she got visibly like anxious, uncomfortable, giggling, blushing, like very discombobulated in trying to talk about what really should have been a conversation about high-risk behaviors rather than the overall risk profile of a patient population with no further explanation. And that really stuck with me, not only the way that she was presenting the information, but the way she responded to my somewhat, you know, let's have a real conversation about this type of question. And it's really been in the back of my mind ever since in my practice, and now going into my doctoral research of wanting to improve the way that we incorporate LGBTQ health topics for those distinct populations into undergraduate training, so that our new to practice nurses coming into the field, which is who I teach here at Upstate, come in better prepared to care for these patient populations and all of their various needs. So that was kind of long, sorry, but that's.
No, that was wonderful. Thank you for sharing. All right, now I'd like to jump into some questions that we have prepared. And Amy, I'd like to start with you. Can you please talk about what sexual and gender minorities are and explain why they are considered a health disparities group?
I sure can. But before we do that, I want to put a little shout out to Pride Month. I don't know how many of you know, 51 years ago yesterday, the Stonewall riots began. And those were really revolts led by primarily Black transgender folks and Black gay men in New York City who were responding to police brutality. They were attacked essentially because of their identities at the Stonewall Inn, which was a popular gay men's bar in New York City. And at that time, you probably know, discrimination was rampant, police brutality was rampant against LGBTQ folks. And so this was really the first like really visible response to that brutality at a national level. People saw it happening. And the gay power movement emerged from that and really birthed this new gay pride that we now celebrate as Pride Month. And I think that it's, you know, really a lovely way to celebrate gender and sexual expression diversity. And millions of people do it across the US, across the world. Buffalo's had its own Pride events for decades now. It was pretty small when I used to go about 10 years ago. We were at Bidwell Parkway on Elmwood Avenue, if any of you are familiar with Buffalo. And it moved in 2011 down to Canal Side, and it's really like bursting in size. They've said that about 15,000 people have attended over the last few years. And so unfortunately, as we know, COVID has put a damper on that this year, but they're trying their best to do some virtual events. But it's pretty exciting. So I'm really glad that Grace was able to organize this month during Gay Pride Month. We're just getting in before the end of the month. So I was going to give you, that background about my research interests, but I just want to move in instead to just some basic terminology, because I want to establish some common language that we can all sort of take off from. And I feel like I'm doing like the briefest little abstract of this. And if you want to go online and look up terms and things, I really encourage you to. These terminology is changing all the time. The National Institutes of Health has increasingly started using the term gender and sexual minorities rather than the popularized LGBTQ plus acronym. And one of the reasons for that is that, and lots of people still use LGBTQ plus, but as you might guess, we just keep adding on like letters. And it still ends up being exclusionary. We can't like capture everyone's experiences in those acronyms, and people get confused by the acronyms. So what's the Q? What's this? What's the plus? And so NIH really has embraced this idea of gender and sexual minorities, and they define it as encompassing lesbian, gay, bisexual, and transgender populations, as well as those whose sexual orientation, gender identity and expressions, or reproductive development varies from traditional, societal, cultural, or physiological norms. And I think most of you are quite familiar with lesbian, gay, bisexual terminology. And as you know, those are sexual identities. So I also want you to think about sexual orientation, which is bigger than just the identities and really encompasses attraction, behavior, and identities. And so, for example, we might have someone in SGM population who, you know, has same-sex intimacy behaviors, but may not identify as gay, for example. I want you to keep that in mind. And the big thing that I really want you to keep in mind that's often confusing to people, and I think they're getting better, but not entirely, is that sexual orientation, sexual identity is distinct from gender identity. I think that's really important. Terms in the gender identity umbrella are those that are often most confusing to people, I think. And they're changing all the time. Like I have a hard time keeping up with terminology. But the Human Rights Campaign provides a really nice, tidy definition of transgender that helps, I think, move us along a little bit in this understanding. And they say that transgender is an umbrella term for people whose gender identity and or expression is different from cultural expectations based on the sex that they were assigned at birth. Being transgender does not imply any specific sexual orientation, which is what I just said. That's really important. Therefore, transgender people may identify as gay, straight, lesbian, bisexual. And so really this is moving us forward in recognizing that gender identities on a spectrum rather than being these distinct binary experiences of male and female that are, I mean, those are embedded in our social, cultural, linguistic usage. And it's recognizing that, you know, that doesn't capture it all. There's a broader spectrum. And some terms that some of you may have heard, you know, along the way in popular culture these days, folks are using terms like gender non-binary, gender non-conforming, gender fluid, and gender queer. And so really I wanted to emphasize that we want to distinguish sexual identity from sexual orientation, gender identity from sexual orientation, sexual identity, not confuse the two because they're important differences. And I also just wanted to sort of gesture at the size of the population, like who are we talking about? How many people are in the US when we talk about gender and sexual minorities? And that's a really difficult statistic to come up with because, you know, most of us rely on the census to tell us how many people with certain characteristics exist in our population. And the census doesn't ask us about gender and sexual identity. And so the best that they do is that they ask folks who they live with and the gender of the person they live with. And so we can capture same-sex partners living in households together, but that really is just a tiny fraction of the population. And so we really don't have any good statistics. The Williams Institute, which is a, you know, well-recognized research institute, they suggest that about 3.5% of the US adults identify as lesbian, gay, or bisexual. And they suggest that 0.3% of adults are transgender. And I want you to also remember when we think about those numbers that bisexual folks make up more than half of the LGBT individuals in the US, and that's often ignored. Bisexuals are often sort of silenced or marginalized, even in the LGBTQ communities. And that's something that's particularly of interest to me. In my work, I've looked a lot at the unique experiences of bisexuals and unique stressors, and they report a variety of unique health disparities compared to other folks that are worrisome and are sort of tied back to this invisibility. So talking about LGBT individuals in the US, they're, you know, 3.5% sounds like, oh, that's not all that many, but that's about 9 million LGBT Americans. And so if you think about the size of the population in New Jersey, that's about how many folks. So it really is a lot, and it really is also an underestimation of those numbers. So yeah, I just wanted to point to the numbers. And so I'm sorry, Grace, did you tell me to talk about terminology and then we're moving on to health disparities? I forgot, sorry.
No, that was perfect. So that was the first part, was just explaining who they are and why they're considered a health disparities group. And then I was going to follow up by asking, what are some of the factors underlying these health disparities among this diverse population?
Yeah, so actually I didn't address part of that. I wanted to talk about them as a health disparities population, and that really just emerged in 2016 when NIH formally recognized sexual and gender minorities as a health disparity population. So now they're considered a health disparities population alongside racial ethnic minorities, socioeconomically disadvantaged populations, and also underserved rural populations. And I want you to remember too that these are intersecting identities, and so we don't have these like tidy little groups of folks. You know, LGBT folks are also, you know, living in rural underserved areas. They're also racial ethnic minorities. So we like to split things up and make them tidy as scientists, but it's not always that way. And so what are some of the health disparities that are experienced by SGM populations? And we're getting a better handle on that right now, identifying riskier health behaviors and ways that they report disproportionately worse health outcomes, but we still have a lot to learn. But some of the population-based findings suggest that SGM folks report riskier drinking patterns, higher rates of some cancers, more severe mental health symptoms. Older LGBs report greater health problems. And we also see higher rates of victimization and violence across the lifespan among SGM populations. And I want you to remember too that these folks are disadvantaged in terms of structural determinants of health too. They report lower incomes, more housing instability, higher unemployment, higher rates of homelessness. More of them are uninsured or underinsured. And as most of you are in healthcare, you understand how critical that is for health outcomes, and that can really exacerbate these poor health outcomes. And they also experience, which Kyle alluded to, and I think both Kyle and Caitlin are going to talk about more, they also experience prejudice in healthcare settings, and that makes them reluctant to seek care, reluctant to disclose important facets of their health that their healthcare providers really need to know to give them the best healthcare, and all that propels them into poor health outcomes. As Caitlin also said, we have to remember that these are really diverse populations. So rates of adverse health outcomes in these risky health behaviors, they vary by gender, sexual identity within this group. As I mentioned, bisexuals in particular, I'm interested in bisexual women's experiences, and they report higher risk than lesbian and gay folks for heavy drinking, poor mental health outcomes, and they experience higher rates of interpersonal violence across the lifespan. And although we have like a good grasp on these population-based disparities, we still are struggling to understand the distinctions among this population and the unique experiences and disparities experienced by them. In particular, the health of transgender folks and gender nonconforming individuals. It's one area that's really growing like immensely, but we still know very little. What we do know is that they are probably at the highest risk and still experience rampant discrimination and prejudice that's built into like our legal system, our social system, and all of these adversely impact their health and well-being and in horrible ways, and they experience a lot of violence. And we see many murders in the US among transgender folks. So why do these disparities persist? Well, I think this is fairly evident, but I want to say it out loud. It's not because this population is like inherently flawed or physically or mentally like, weaker in some way. Instead, it's about sexual minority stressors. They experience these unique stressors, and that's what drives health disparities. In fact, back in 2011, the Institute of Medicine released a really groundbreaking report that underscored this message. They said if one examines the historical trajectory of LGBT populations in the United States, it's clear the stigma has exerted an enormous and continuing influence on the life and consequently the health status of LGBT individuals. And that was 2011, 9 years later, we're still in the same place, sadly. So where does this sexual minority stress really come from? And I think it's really rooted in heterosexism. And there's been a lot of conversation about racism, and heterosexism is, functions very much like racism. It's a system of interrelated cultural, legal, social structures. It's systems of discrimination and bias. There are all these attitudes that assume and presume that heterosexuality is the norm, and anyone that doesn't abide by that expectation is stigmatized and marginalized, and this adversely impacts their health and well-being. And so, implicit, explicit discrimination and prejudice emerges from that. So, there are things like microaggressions. We've been talking a lot about microaggressions as they relate to racism. Very similarly, SGM populations experience all sorts of microaggressions, and I'm sure we're going to be talking more about that in terms of like healthcare microaggressions and how that impacts people's health. It's really critical that we address that in our systems. So anyways, that was sort of a long-winded. I feel like I hardly touched the tip of the iceberg, but I wanted to just say something about terminology, something about the disparities, something about, why they exist. And I thought that would create like a nice foundation for Caitlin and Kyle to move toward more into talking about how this relates to the healthcare systems and training of nurses and clinicians.
Absolutely. Thank you so much, Amy. That was incredibly informative. So now I want to talk a little bit to Kyle. Kyle, what do you think are the most effective ways to ensure that healthcare providers are able to provide LGBTQ+ competent care?
Well, first of all, I want to start by thanking everyone for coming today. I think it's incredible how many people we've got to gather here for this, especially here at the end of Pride Month. And I also want to thank you, Amy, that was a great discussion. I'm going to start off by reading just a short paragraph from, I'm going to show you this. It's called Improving the Healthcare of Lesbian, Gay, Bisexual, and Transgender People. And I'll give Grace the link to this article to send out in the post email, because it's a very informative and succinct way of understanding it. It's just very well written, but I'm going to read the first paragraph in the introduction because I think it's important. It says, the LGBT community is diverse. Well, LGB and T are usually tied together as an acronym that suggests homogeneity. Each letter represents a wide range of people of different races, ethnicities, ages, socioeconomic status, and identities. What binds them together as social and gender minorities are common experiences of stigma and discrimination, the struggle of living at the intersection of many cultural backgrounds and trying to be a part of each, and specifically with respect to healthcare, a long history of discrimination and lack of awareness of health needs by health professionals. As a result, LGBT people face a common set of challenges in accessing culturally competent health services and achieving the highest possible level of health. So I wanted to start off with that because it just kind of gives an overview of exactly what Amy presented in her presentation there. And I also want to say that a lot of my knowledge and understanding of LGBTQ+ healthcare comes kind of back to the clinical side of things, as I was in the family nurse practitioner program. So I definitely was more clinical focused in my understanding of it. So I'm going to go through like 4 or 5 of what I believe and what I found in my research to be the most effective ways to ensure that healthcare providers are able to provide competent care to sexual and gender minorities. So the first thing I want to talk about is the need for continued scientific research with sexual and gender minorities. Amy briefly touched on, about how about 3.5% or 9 million people identify as LGBT adults here in the United States. But I think that what's also important to recognize is that she said that we lack in our national implementation of surveys that are able to capture how many adults identify as LGBTQ+. And there's a number of reasons for that. And some of the reasons are as she touched on, there's an incomplete overlap between attraction, behavior, and identity when it comes to sexual orientation. Additionally, another thing that might impact the result of these scores is the fear of interview respondents to accurately answer these questions, because there might be fear of stigmatization or discrimination. And also, another thing to address with that is just the general lack of LGBT health research. You know, we need to increase the number of researchers that are interested in gathering this sort of data, so that way we can provide healthcare providers with more accurate numbers of people that actually identify as part of sexual and gender minorities. In part because when we can convince healthcare providers that there is a significant number of people that identify as these populations, we can get buy-in from healthcare providers to actually want to learn about this stuff and understand the need to learn about it. And I think that part of the solution with increasing and improving LGBTQ plus health research is to get the support of federal government organizations that actually provide grant and funding, grant money and funding to support LGBTQ plus research. At the end of the day, a vast majority of research that is conducted is directed through money that's appropriated by Congress and then, you know, channeled through different federal organizations. And without this sort of funding, it's hard to actually be able to improve LGBTQ plus research. And as Amy had touched on in the beginning, one very positive thing for the LGBTQ plus community is that the National Institutes of Health in 2016 actually made the LGBT community a priority population for research in health disparities, which is very important. And also, Healthy People 2020, another major directing organization on the federal level, has made it a goal to improve the health, safety, and well-being of lesbian, gay, bisexual, and transgender individuals. So that's another goal of theirs. So number one, I would say, continuing to work as a scientific community to gather LGBTQ plus healthcare data. The second thing that we need to do, and I'm not going to go into too much detail with this one because Caitlin's going to touch on this more next, but undergraduate nursing educational institutions need to do a better job of implementing LGBT-specific training in didactic and clinical settings. Now, there's a slew of research that supports the fact that undergraduate nursing programs majorly lack in their implementation of LGBT health education. Now, this is problematic because undergraduate nursing education provides the foundation for nurses to build on their LGBT competence. So without that foundational education, of course, nurses are going to be lacking as they continue to grow in their clinical settings as professionals. And I also want to say that the failure to implement LGBTQ plus education in undergraduate nursing programs is particularly problematic for advanced practice nurses, such as family nurse practitioners like myself, because that foundation that we're meant to build upon is already lacking. So it basically sets us back when we are meant to be managing care for this population. So then that actually brings me up to my next point, and that's actually the focus of a lot of my research in my doctoral program is how advanced practice nursing educations at the graduate level need to incorporate LGBT-specific training into their programs as well. In my research as a doctoral student, I came across many very scary to me, scary knowledge disparities in both nurse practitioner students and nurse practitioners, coming down to very basic components of LGBTQ plus healthcare, such as basic LGBT terminology, and also important things like failure to recognize nationally recognized guidelines that are specific to the LGBT community. So part of the educational component that needs to be included in advanced practice nursing programs is the recognition of national guidelines that are specific to the LGBTQ plus community, such as the CDC guidelines that outline for gay and bisexual men and other men who have sex with men that may not identify as gay or bisexual should be screened for HIV annually, syphilis annually, as well as gonorrhea and chlamydia screenings annually. And I'll provide a link to the CDC guidelines that I just mentioned in email that will be sent out later in case anyone wants to see it. And I also think that it's important that advanced practice nursing education incorporates transgender specific guidelines into their training, because there is definitely a distinct lack in transgender specific health research. I mean, it's improved specifically within like the last 2 years with the guidelines and stuff that have come out, but there's definitely a great lack in research that specifically addresses transgender communities. For example, I mean, transgender specific health guidelines like that transgender females over 50 years old who have been on hormonal therapy for 5 years or more need to have mammography screenings. And I think that it's important, especially for primary care providers like myself, to recognize these guidelines, because ultimately we're going to be the ones that are ordering these diagnostic tests and following up with them. So it's important that we're able to recognize the guidelines, because if not, then we're actually doing our patients an injustice, because we're not providing them with the best care possible, and we're also not following guidelines that way. Another thing that I wanted to point out is that undergraduate nursing education and graduate nursing education needs to do a better job of incorporating the fact that the LGBTQ plus community is very diverse, but ultimately that the binding factor between them, as I mentioned earlier, is the experiences of stigma and discrimination. And that's kind of what groups them together. But there is a great deal of intersectionality within the LGBTQ plus community that impacts different members of the community. For example, about a little over 2/3 of all new cases of HIV in the United States, and the only population where HIV is actually increasing in numbers, is among like young Black and Latino men. So understanding, and research has come to find that it's not actually the risky sexual behaviors that occur among these populations that seem to account for the increased number of HIV cases among them, but rather systemic disadvantages such as low rates of health insurance and inadequate access to different medical regimens like pre-exposure prophylaxis. So it's important to recognize that there is intersectionality that actually contributes to worsened or more marginalized health for certain members of the LGBT community. And the fourth thing that I want to talk about is that healthcare institutions, whether that's at a primary care provider's office, whether that's at a hospital setting, need to do a better job of creating an inclusive environment for all LGBT people. And this includes the provision of policy that works to protect LGBT patients in healthcare institutions. For example, a major point in research is using intake forms that actually address sexual orientation and gender identity. In fact, the Institute of Medicine recommends that healthcare institutions include structured data fields to obtain information on sexual orientation and gender identity as part of electronic health records. Because I know, for example, in my experience as being a patient in healthcare, very often healthcare providers, they don't ask about sexual orientation and gender identity. And research shows that part of the reason that healthcare providers don't ask patients about sexual orientation and gender identity is that they fear that patients may not want to be asked about it. But research actually contradicts that point to a T in saying that patients that are asked about sexual orientation and gender identity in healthcare settings actually very often feel more comfortable going to that healthcare provider because they know that they're addressing them holistically and that they're not disregarding something that is very important to their life and also to their health. And with that being said, of course, there are various ways that institutions can work to ask these questions and make patients feel comfortable. For example, by using intake forms that the patients fill out themselves to make sure that they, feel comfortable asking the questions. They don't feel pressured to answer one way or another. So ultimately, in my opinion, and also there's a slew of research to support this, the greatest challenges that face healthcare providers when it comes to caring for sexual and gender minorities comes down to one simple word, and that word is unpreparedness. Healthcare providers are simply often do not have the educational background and the training to successfully care for LGBTQ plus adults. The nursing educational system needs to work more aggressively to ensure that nursing students in undergraduate and graduate programs are equipped to address the healthcare needs of LGBT adults. And that comes down to educating them on LGBT health. And in many ways, providing culturally competent care to LGBT patients, it doesn't differ from providing patient-centered care to any population. It comes down to, addressing patient-specific needs, meeting patients where they're at, and having open and direct lines of communication without fear of asking your patients, what their needs are and how you can better help them, meet their goals and objectives. There are a couple resources such as the Center for Excellence for Transgender Health that provides a slew of guidelines with regard to transgender individuals that I'm going to provide the link to Grace to send out to everybody so that way everyone can have that. And another one is the Endocrine Society Clinical Practice Guidelines that actually addresses prescription and monitoring for hormonal therapy for transgender adults, in case anyone wants any additional information on that. And I guess I just want to finish by saying that I'm very happy with the tremendous progress that we've made even in the past decade with regard to LGBTQ plus acceptance here in the United States, and even as recent as the most recent legislation that was passed by the Supreme Court that outlaws job discrimination for gay and transgender individuals in the workplace. I think that it's important that we as a society are moving forward and people are becoming more accepting. While the acceptance is there, we need to also make sure that that is reflected in clinical practice, which right now, unfortunately, it's not. So that's where the disparity exists, and we need to make sure that people are accepting, but we need to make sure that we can continue to address the disparities that are rampant with LGBTQ plus adults in the healthcare setting. So thank you, everyone.
That was great, Kyle. Thank you so much. And you touch on some really great points that are going to lead in perfectly to my next question, which is for Caitlin. Caitlin, can you tell us a bit about how this all looks in an undergraduate setting? So what are the building blocks used for an undergraduate education, and what barriers do you face?
Sure. So I wrote this down and underlined it as Kyle was speaking, which is the word unpreparedness, because not only are we potentially launching new to practice nurses into the clinical practice setting or underprepared to care for these different patient populations. They're educators, which I include myself in that category, and many of the guests to this panel today are their current or future educators of undergraduate and I'm talking about from my research interest standpoint, pre-licensure undergraduate nursing. So folks who are in associate's degree programs or in standalone four-year BSN programs, folks who are truly entering the field from their undergraduate experience. I'm seeing one of my colleagues, Mary Catherine Harmon, on this call, and she teaches an RBSN completion program, which is a little bit different because those are practicing nurses finishing their baccalaureate. But anyhow, that or under preparedness, I think, is something that is experienced both by those new to practice clinicians entering into the field, but by their faculty as well. And so Kyle cited a couple of the statements that are sort of forefront on my mind when I think about nursing faculty preparation to teach and incorporate LGBTQ plus health content. I'm going to start adopting Dr. Hequembourg's SGM because it's shorter and more accurate. But one of the statements that's come out in our field just in the last couple of years is from the ANA Ethics Advisory Board, released a position statement in 2018 calling for culturally congruent care advocacy for these patient populations. And one of their primary recommendations in this position statement is that nurse educators will help fill the void in knowledge by incorporating the issues of the LGBTQ plus populations as part of nursing curriculum. And judging by some of the sort of initial forays into searching the literature on this that I have found, that is a recommendation that is a lot easier said than done. And there's a few reasons for this. One of the primary reasons, I think, is that sense that faculty themselves may not always feel that they've been given appropriate training or guidelines or information themselves about how best to address not only the health disparities, and I think we often place a lot of emphasis on the negative health outcomes that are that these SGM populations are at higher risk for, but even just different kinds of healthcare needs in primary and preventive care as well. So the kind of work that Kyle does as a family nurse practitioner. So all of those things I think are in the undergraduate setting under addressed. And I know this because having looked at a lot of the literature on this, there are some studies that dug as far as to say, okay, how many hours are you spending in your program on SGM health topics? And I found everything from 0 to maybe about 5 total across addressing in North Carolina and Texas, sort of statewide, what is the coverage of these issues. My favorite is a faculty member who took the open-ended response box as the opportunity to write "not enough" in all caps, exclamation point, exclamation point. So I think that there's an eagerness and an interest there on the part of many nursing faculty, although other studies suggest that there are faculty who either because of their own personal situatedness or experiences or beliefs may express in the anonymity of a survey, express some discomfort in teaching these healthcare topics. And I think it's really important to address the fact that teaching important healthcare disparities is a non-political issue. It's a way that we prepare our providers to care for our patient populations across the board. So that's one consideration that I think is worth talking about. In other instances, a lot of faculty may have felt interested in teaching it, but not quite sure how to incorporate it. We can all appreciate all of the wonderful and incredible things we want to cram into our curricula and the limited amount of time that we may have to do so. And if SGM health is sort of considered an add-on or an extra, I think of my textbooks that had insert boxes about different types of patient populations. We as educators may feel like, well, I don't really feel comfortable, or I don't have enough information or even enough time. And that's really what the literature tells us across the board. It's not for lack of interest. In some instances, faculty expressed a great interest in or even a sense of preparedness for teaching these healthcare topics. In one of the studies that I looked at, fully 70% of nursing faculty said that they were moderately or fully ready to teach these topics. And then as much as 63% said that they never or seldom actually taught them. So some folks may self-assess a great level of preparedness, but not sort of see a way to fit it into their teaching practice. Some faculty have suggested in some of these studies that accreditation standards, NCLEX questions, these sort of structural policy level things may be what's required in order for nursing faculty to really look at their curricula and figure out ways to incorporate these health topics better into their programs. But I think my focus, and I am only in my second year, I don't know how much longer I get to play the new kid card, but I am currently really interested primarily in those percentage of nursing faculty who do not report a moderate or high level of preparedness. How do we first empower faculty to feel more well-versed and more comfortable in a landscape which, as Dr. Hequembourg says, is shifting all the time, both in terms of what we understand from a research standpoint about SGM health, but even at the level of terminology and populations and identity health. I think those things are really important to address, perhaps in addition to, or maybe even before, looking at some of these policy considerations. One thing I really wanted to also talk about briefly is that in my research, or in my literature searching thus far, a lot of the other things I've found actually have to do with assessing undergraduate nursing students' experiences of a whole variety of what I call educational interventions. So whether it's a simulation, a lecture, a role play, a group of students going to a Pride Parade health fair, all of these different things, and sort of understanding what's the impact on those student learners. And I don't know if I'm allowed to do this yet, Grace, but one of the things I was hoping to do as part of this panel is kind of like put this question out to the listeners here to talk about what was your exposure, if any, to LGBTQ, IA plus / SGM, all of the letters, health in your undergraduate training. Because if the background is there's faculty who have a variety of levels of comfort in teaching these topics or incorporating them, or feeling like they're supported and able to and have the time and capability, and some don't. So I'm just so curious to know what people's undergraduate experiences were with these, because those deficits, or those knowledge gaps that Kyle so nicely articulated, that lead into deficits and knowledge gaps in advanced practice, undergraduate education is where we can start to change those things. So that's why that's really the focus of my research. So the very short answer is there's a lot of opportunity there for sure.
Thank you, Caitlin. Did anyone want to respond to her question about what their undergraduate experience was like?
I can respond to that. Hi, everyone. I'm Abby. I'm in my 4th year of the FNP program. I'm currently talking from an office at Clinical, so I have to step out soon because lunch break's almost over. But I would agree with, I think I would have been one of the people to fill out the way Caitlin commented on that one teacher, where it simply was not enough. And it's one of those things too, where I catch myself, like Kyle said, I'm like, oh, I'm not even, asking the question all that often. And I catch myself, especially with female patients, abdominal pain, I'm ruling out pregnancy as one of my differentials pretty early on. And I'll catch myself saying, are you sexually active with men or women? And that's only something that I just recently got comfortable even asking, because I should be saying that instead of being like any risk for pregnancy and dig deeper. But it's still one of those things where, I identify as an ally and someone who would like to be better, but it's like almost understanding the language better would probably be better for someone like me. But it does seem like it's a topic that we barely address. And I know in our meeting last week, some students had actually discussed, making that more of a focus for the undergrad RN students in their nursing seminar class, because I think that was probably the only time that we did discuss it.
Wonderful. Thank you for sharing that. Would anyone else like to comment about their experiences?
I'll date myself for sure. Graduating from an undergraduate program in the 1980s, the late 1980s, we certainly did not have any education about this, and there was certainly no discussion about it. And I think what I have learned, especially working with Kyle on his DNP project, and I learned so much from Kyle, and we had many great discussions, and it just really reinforced the need for this research and the education among providers and future providers on how to take care, of these populations. It's just, what I have done is, my kids are so much more socially receptive and open to talking about these topics. I have learned so much from students. I've learned so much from my kids' friends, and just being open-minded and, receptive to learning about people and their needs. I mean, we're going to talk about holistic care, respecting everybody's dignity and right to health care. So I love that the research is really taking off. I love that students are starting to do their PhD, their dissertations, and these projects are starting to focus on this. So it is really wonderful to see. And I'm just so grateful for the experiences that I've had. But speaking for myself again, from the late 1980s, it's always been a problem. So it's exciting to have people focus on this and, let's make this better for sure.
Wonderful. Thank you so much for sharing. Now, I know we're coming up close to the hour, but I do want to have an opportunity for everyone to ask questions. And I'd like to begin with one that was pre-submitted by Dr. Somayaji here at the School of Nursing, who is an Oncology Nursing Society Rapid Response Team member with other cancer nurse scientists across the US with the goal to address COVID-19 and health discrimination and health disparities. Her group wants to offer solutions to transform healthcare as we know it. They want oncology nurses to be part of the conversation and the solution. So her specific question to the presenters is, what recommendations can I bring back to the rapid response team to consider as we examine the current state of the science, identify gaps inclusive of LGBTQ+ populations, and propose research priorities needed to build our science and transform the future of healthcare? So if any one of you would like to comment on that, please feel free.
I can say something. I've jotted down a couple notes just in response, and I'm not sure that they're necessarily specific to oncology nurses, because as we've heard, this problem really, this undereducation and undertraining of clinicians is across the board. But I think we need to do a better job at identifying cancer disparities in SGM populations and understanding the mechanisms underlying those. We're just starting to get a grasp on, like, what subpopulations are experiencing and reporting higher rates of cancer, different sorts of cancer. And we don't really know why. Why is that? How do sexual minority stressors play into that? How do risky health behaviors, higher rates of smoking, higher rates of drinking, things like that play into that. So we definitely need that. And we need to better address healthcare microaggressions and heterosexist assumptions that permeate healthcare training and healthcare teams. And like I said, that's no different than elsewhere in the healthcare system. And I think, training for cultural humility regarding SGM individuals for oncologists could help. And, oncology nurses, like simple things like just not making any assumptions about who the other person in the room is when you're caring for your patient. Don't assume it's her sister. Ask and get and find out, and ask people what sorts of pronouns they prefer, and just like simple things like that can open the door to people sharing more about themselves that will help improve in their healthcare, I think.
Wonderful, thank you, Amy.
I wanted to add one other thing to that with Dr. Somayaji's question about specifically with regard to oncology nursing. One thing that I've come across with regard to knowledge disparities and with healthcare providers in the clinical setting is that specifically with regard to transgender patients and different oncology guidelines. For example, I mentioned during when I was presenting that transgender men who undergo, or transgender females who are undergoing hormonal therapy, after the age of 50, and they've been on hormonal therapy for over 5 years, they need to be having mammography screenings. So I think that there needs to be more knowledge, more easily accessible knowledge to healthcare providers on guidelines that are specific to transgender patients who undergo various gender affirmative surgeries with regard to cancer screening guidelines. For example, a transgender male who continues to retain their cervix still needs to have a pap smear done. So I think that it's important for healthcare clinicians, especially in the primary care setting, to recognize these guidelines, because ultimately, again, we're going to be the ones that are ordering the tests for these patients, and we're going to be the ones that are following up on those tests. So there needs to for sure be more information available to healthcare providers with regard to that, and also more research conducted in that setting, I feel.
Great. Thank you, Kyle. We had another question comment from Christopher in the chat. Kyle, you might want to answer this one as well. He said, Kyle had mentioned guidelines that recommend specific diagnostic testing for patients meeting certain criteria, such as transgender women on hormonal therapy. In addition to understanding the guidelines, what experiences or difficulties do clinicians face with regard to insurance companies? Are clinicians equipped with the tools to challenge insurance companies that may deny payment for certain populations, specifically those within the LGBT community?
Yeah, I think that this is very important, and for me, this kind of comes back to it comes back to a political aspect of it all, because you know, over 80% of or somewhere around those numbers, over 80% of all patients that we take care of, at least in this area in Buffalo, are going to be insured either through Medicare or Medicaid. Okay, so it comes down to yes, with Medicare and Medicaid, with regard to hormonal therapy for transgender patients, most of the time, so long as you go through all the processes that are outlined by these institutions, then you should be able to, you know, provide this care for patients. However, this is actually a dispute I had with a coworker not too long back about they didn't believe that, you know, Medicaid and Medicare should cover gender affirmative surgeries for transgender patients because of limited anecdotal experience they had where there was a bad outcome, which of course you can't use anecdotal experience to generalize to a larger population, which we all know that. But we continue to face barriers as healthcare providers with making sure that we can provide care for transgender patients, specifically with regard to gender affirmative surgeries, because they're all evaluated on a case-by-case basis, at least by Medicaid and Medicare. So sometimes, even if you go through all of the specific guidelines that are set out, which includes, you know, psychological evaluation by psychiatrists, because the patient has to have had a diagnosis of gender dysphoria per the DSM guidelines, as well as some other strict criteria that are set out there. You know, sometimes the unfortunate fact of the matter is that we aren't able to have these gender affirmative surgeries covered by insurance for patients, which in those cases there are various other outlets that you can go through to help help patients get funding for these surgeries. But certainly that still presents a barrier to this day. I mean, it's unfortunate. I did clinical hours down at Evergreen Health here in Buffalo, which treats a large percentage of the transgender population here in Buffalo, and we continuously face barriers where transgender patients that wanted to have gender affirmative surgeries done had to cover costs out of their pocket because their insurance wouldn't do so.
Thank you, Kyle. Now, I don't see any more questions in the chat, but we might be able to squeeze one more in if anyone wants to ask before we sign off. So now's your opportunity to unmute yourself. All right, well, seeing none, I think that means it's time to wrap up. I'd like to give a huge thank you to everyone who joined us today, and a special thank you to our panelists. I believe we all learned so much just in the past hour alone. This was a wonderful and productive conversation, and I hope we're all ready to continue it, whether at work, at school, or in the community. As a reminder, we are following up with an email with the recording and any links that were discussed today. So please be on the lookout for that. Perhaps by the end of the evening, we should be able to get that out to you. If you did have any questions that you come up with later or anything that you didn't want to ask right now, feel free to reach out to me directly. My email is grace@buffalo.edu, or you can respond simply right to the email that we'll be sending out, and I'll be able to get a response to you. And then lastly, I just want to let you know that we're going to be holding these virtual events monthly throughout the end of 2020. So if there's any specific topic that you would like us to cover or you want to learn more about, please send those ideas to me as well. You may either send it directly to my email or feel free to just respond to that follow-up email you'll get later today. Just a little sneak preview, our next event will be held on July 21st, and the topic will be how to prioritize self-care during a pandemic. So please be on the lookout for an email invite to that in the coming weeks. But that is everything. So I wish you all a wonderful week, and I look forward to connecting again in July. Have a great day.
Thanks everybody for coming.
Thank you.
Thank you, Grace.
Of course, thank you all.